My name is Suzanne Archie. I am a psychiatrist. I work out of Hamilton in Ontario in Canada. And I work with young people who are experiencing a first episode of psychosis. I work with a lot of young people and their family members who struggle, who find it a challenge to navigate their pathways to care. And what I'm going to be talking to you about today is a systematic review, a literature review that we synthesized to look at how 3 different ethnic groups navigate their pathways to early intervention in psychosis care. And what I'm going to do is, first of all, I'm going to provide you with some background about pathways to care research and first episode psychosis. Next, I'm going to talk about why we actually focused on young people of African descent in the pathways and some of the vulnerabilities that people of Black African descent have experienced with respect to psychosis and pathways to care. And then finally, I'm going to talk to you about the systematic review that we conducted. Okay, so very basic to start. What is first episode psychosis? Well, I'm sure most of you are familiar with psychosis, but first of all, people will experience disturbances in perception, so often hallucinations, fixed unusual beliefs or delusions, and with that, people can experience confused thinking and speech, as well as dramatic changes in mood. People often don't realize that young males, in particular, with first episode psychosis, one of the highest risk groups for completed suicides, not attempted. Attempted suicide is usually, young females with depression, but for actual completed suicide, it is young males with the first episode of psychosis. And I should explain that psychosis can significantly impact daily functioning. And we define first episode for the studies as people who have experiencing psychosis for the first time, receiving up to 1 year of treatment, because many of the clinics that treat first episode psychosis will see youth as long as they have not been treated for usually 6 months, but in other studies and in other countries up to 1 year. The other important information to realize is that psychosis onsets between the ages of 15 to 29 years of age, but in fact the highest peak, particularly for young males, is 18 to 24 years of age. For females, there are 2 peaks. A younger peak between 15 and 29, and then a second peak around menopause, 40 to about 50 years of age. Annual incidence of first episode of psychosis. So incidence, by that I mean the number of new cases. It's a lot more common than people think. For schizophrenia proper, the rate is 8 to 15 people per 100,000 between the ages of 15 to 50 years of age. That's the age of risk. But for psychosis in general, which would include bipolar illness, substance-induced psychosis, delusional disorder, it's much broader, 20 to 42 per 100,000 people between the ages of 15 and 50 years of age. So, for example, in the Greater Toronto area, city of over 1 million people, you'd expect at least 2,000 new cases of first episode psychosis a year. Okay, So early intervention in psychosis, what is this? Early intervention in Ontario, which is the province that I have come from, the government funded 33 early intervention programs to serve first episode psychosis patients and their family members. And there's a variety of services associated with these EPI or early intervention programs. So there's early identification, specialized psychiatric assessments, medication management is certainly the cornerstone, psychosocial interventions like cognitive behavioral therapy and family education and support, as well as a number of ancillary services associated with that. So helping people access primary care, family doctors, crisis intervention, education and employment supports are very critical. So there are often occupational therapists, social workers, nurses, psychiatrists, recreation therapists. They're very well-resourced services geared to help youth, usually up to 2 years, but can be longer, to kind of help intervene early, keep youth in school, keep their career trajectories, help them achieve their goals. So early intervention is really the target service for the pathways to care. But the question is, are people getting there? How many people actually know about these services? Do family doctors even know about these services? Okay, so this is a study which I did along with others in Ontario at university early intervention programs, looking at the pathways to care, which is a sort of a visual depiction of how people get care. So first of all, if you were seeing a psychiatrist or a psychologist already in treatment and then developed psychosis as part of that, you had a very direct route to EPI or early intervention services. But if you were seeing other non-medical contacts, so school counselors, social workers, elders in the community, then you had this very complicated indirect route to early intervention services. If you went to see your family doctor first as the first contact, then you often ended up being directed to emergency services and then often getting admitted and then getting to early intervention programs. And at least 28% of the youth just went to emergency first and then were directed into hospital and then went to early intervention services. So, you know, this confusing diagrams just shows how challenging it is for youth to get directed to this care. So now I'm going to focus on why did we have this particular interest in youth of Black African or Black Caribbean descent. Because in this study, the 3 ethnic groups, I forgot to tell you, that we actually examined in the literature for their pathways to care were Black African, Black Caribbean, and white European groups. And so first of all, what do we mean by these terminologies, Black African, Black Caribbean? We decided to look at ethnicity, and it was defined, people self-identified what group they felt that they belonged to. And so we sort of saw it as a social, as opposed to a racial classification, that the terminology Black has been reclaimed through the civil rights movement to really represent a cultural identity through art and music. But at the same time, we recognize that people of Black African descent with all of the strengths inherent in these communities, there's also an increased vulnerability around psychosis that we wanted to advance knowledge around and understand. And they're just focusing on the vulnerability. There have been a number of meta-analyses looking at migration and schizophrenia for people who immigrate. And so people, Black African or Black Caribbean people living in either Africa or the Caribbean, the risk of psychosis is not any greater than in any other country or, in any other country. But when people immigrate, first generation to European countries, the risk of psychosis almost triples. For the second generation, so people who are children of the people who immigrate, the risk increases almost 5 times. For developing countries in general, the risk is 3 times, but where a majority is Black and they immigrate, the risk can increase almost 5-fold. And this is a meta-analysis. There have been at least 20 or 30 studies looking at this phenomena, finding this this risk pattern. And so what we wanted to do was, first of all, look at whether there were certain vulnerabilities or risks inherent in how people were accessing care. Were there any signs of inequities in how people were accessing care, signs of vulnerability, comparing Black, African, Caribbean, and European groups. That was our original question, but when we actually looked at the studies, it became apparent that we just needed to compare Black groups versus white groups because the literature just wasn't discriminating enough to actually look at more relevant cultural groups. So we had to lump. The objectives, the objectives of the study was to look at differences in the pathways to care for those 2 groups. We did an electronic search using Medline, Embase, PsycInfo, the inclusion criteria, measures of pathways to care for first episode psychosis populations. We conducted in high-income countries, North America and Europe, and the papers needed to be in peer-reviewed journals. All of the studies were reviewed independently by at least 2 people. We conducted a meta-analysis and we rated the quality of each study.
You have only 3 minutes left.
Okay. This is a forest plot showing individual and pooled odds ratio for the likelihood of family doctor involvement in the pathways to care. We have the gold stars between the Black versus the white group, and also below the gold star for the Asian versus the white group, and there were 7 studies for the Black versus white. And as you can see, for family doctor involvement, the Black group was significantly less likely to access care through family doctors when you pooled the results of all of those studies. For the Asian group, there was no significant difference in terms of family doctor involvement. Next, we did a forest plot of police involvement for each of these groups. And for the Black group, the likelihood of police involvement was significantly higher, whereas for the Asian group, there was no significant difference compared to the white group. And so, in conclusion, we thought that the pathways to care, there were a number of challenges, and in order to reduce vulnerability for particularly vulnerable groups, we thought there needed to be strategies to help reduce involuntary routes into care. There needed to be strategies to actually strengthen therapeutic alliance with primary care and improve access to care for vulnerable groups. And one of the things that we're looking at, we've just received some funding to do a video game which we're collaborating with game developers in Greece to help youth understand what psychosis is, understand a bit about the risk associated with marijuana use, but in particular, how and where to find care for these symptoms. So they would play the game, there would be animated maps of where they could go in various communities to get help for various symptoms. And that's it.